In our introductory video, we talked briefly about the symptoms of fear of harm. But now that we understand a bit more about how the DSM uses symptoms to diagnose mental illness, let's take a deeper look at our second topic. What are the symptoms of fear of harm, and what do they look like in real life? So, let's look at the proposed diagnostic criteria that have been developed by the researchers who first identified fear of harm. In order to be diagnosed with fear of harm, a patient would have to demonstrate all of the first 6 of the following criteria: episodic and abrupt transitions in mood states, fear of harm, thermoregulatory disturbance, aggression, sleep-wake disturbances, that the symptoms are not due to a general medical condition, and that there's a family history of recurrent mood disorder and/or alcoholism. Now, let's break this list down to look at each item by itself. Episodic and abrupt transitions in mood states. It's in this first criteria that we see the classic bipolar disorder symptoms that you might already be familiar with. These include rapid and unexpected mood swings with symptoms of depression and mania or hypomania. The depressive symptoms include feelings of sadness, irritability, loss of interest in activities that the individual used to enjoy, feelings of worthlessness and helplessness. Symptoms of mania can include racing thoughts, irritability, distractibility with high goal-directed fixations, which we call mission mode, and grandiosity. Hypomania can look similar to mania with a slight decrease in its intensity. In fear of harm, these mood swings happen quickly, sometimes without any warning or outside stimulus to explain the shift, and the child can switch back and forth from depressive to manic symptoms throughout the day. Manic and hypomanic symptoms often occur in the late afternoon or early evening as the day is winding down and the child's mood is winding up. But they can occur at any time, with these mood changes between depression and mania persisting throughout the day. Fear of harm. This is one of the criteria that gives this disorder its name. Fear of harm is what it sounds like. It's the child's fear that they or someone they love will be harmed, usually in some terrifying way. These fears go beyond normal childhood fears and exist as huge, extreme fears that leave the child on constant alert, looking for threats and dangers they are convinced are there, waiting to harm them. They create elaborate rituals at bedtime, mealtime, or bath time to protect themselves from that perceived harm. Separation anxiety, fear of germs, fear of intruders, or of the dark can be pushed to the extreme, severely limiting the child's ability to function normally in school, at home, and in the community. Also a part of the fear of harm symptom is the distorted reactions children have to normal stimuli in their environment. These children see threats that don't exist, either by misperceiving something neutral in their environment as threatening, or by feeling excessively defensive as a result of feeling embarrassed, misunderstood, unheard, dismissed, or rejected. Everything from simple limit setting to minor corrections or redirection can be misperceived as threatening or as a loss and result in aggressive and reactive responses that seem to outsiders as disproportionate or inappropriate to the situation. But seeing threats where they don't exist plagues those with fear of harm, encouraging their fears and perceptions of danger. Thermoregulatory disturbance. Here we have what may be the most important item in our diagnostic criteria list: the body's inability to correctly regulate its temperature. It's what's called a biomarker And while we'll explore what that means in depth in the next course series, what you need to know now is that it's a game changer. Fear of harm is the first ever mental illness with a biomarker. This means that there's a physical symptom from which other symptoms flow. Treating this biological symptom helps control the other behavioral symptoms and helps the patient stabilize and manage their mood and behavior. So, what do thermoregulatory disturbances look like? Well, the most noticeable might be that kids with fear of harm often feel hot and sweat when the climate around them doesn't call for it, like in normal room temperatures. These neutral ambient temperature environments don't feel so neutral to fear of harm kids, and they may go from feeling excessively hot in the evening to cold in the morning, which is the opposite to the body's expected temperature rhythms. Some telltale signs of temperature dysregulation are bright red ears that are often warm or hot to the touch as the body tries to get rid of excess heat that builds up in the core. Another sign is a refusal to wear weather-appropriate clothes, for example, wearing shorts in the winter when it's cold, or refusing to wear a coat in freezing temperatures. They also experience little to no discomfort when exposed to the cold. Aggression. These behaviors that go along with the criteria of aggression can be difficult to differentiate from either normal childhood behaviors or from other diagnoses that have already made their way into the DSM. It's considered developmentally normal for a toddler to have a tantrum over either rational or irrational setbacks. Those tantrums usually last a few minutes, a few may run as long as an hour, but in non-diagnosable cases, the longer tantrums are rare. In a child with fear of harm, tantrums can and will last much longer nearly every time, with tantrums regularly lasting 30, 60, or 90 minutes. They're also accompanied by physical and verbal aggression. Screaming, throwing things, slamming doors, putting holes in the walls, kicking, hitting, biting, and scratching, all part of the tantrums, and these behaviors escalate with the child's age to include cursing and verbal threats. Parents know when their child's tantrums are unusual and deviate from the developmentally normal outbursts that occur in early childhood. Additionally, aggression is shown in other non-tantrum related ways, such as defiant and oppositional behavior, as well as refusals to follow simple instructions, complete expected tasks, and engage in basic chores such as teeth brushing, showering, completing homework, and getting dressed. These requests can be met with verbally abusive responses from the child, which can then quickly escalate into tantrums, leaving parents, siblings, and caregivers feeling as though they're walking on eggshells, never certain what interactions will be fraught with aggression and the potential for violence. These resistant behaviors and tantrums continue well past appropriate ages and leave families feeling exhausted and burned out. Sleep-wake disturbances. Children with fear of harm usually begin displaying sleep difficulties in infancy. Many parents report that their children never slept properly, even as babies. Some didn't develop the ability to truly sleep through the night until after starting treatment, which in some cases wasn't until the children were in their teens. We're able to identify these sleep-wake disturbances in 3 different ways. First are issues such as sleepwalking, bedwetting, and bruxism or teeth grinding, all of which are things that demonstrate problems with the proper execution of sleep cycles. The second are issues related to fears of going to sleep because of the ongoing and recurrent nightmares and night terrors that fear of harm patients experience. These nightmares are filled with violent and often gory imagery involving scenarios where they or someone they love is being hurt maimed, or killed. These images linger with the patient long after they awaken and often plague them throughout the day, reappearing whenever their eyes are closed or whenever they have a quiet moment without external stimulation to distract them. While nightmares are consciously remembered after waking, night terrors, on the other hand, most often aren't. But night terrors are just as traumatic because during a night terror, the body and brain are reacting to the frightening dream events and images as though they were really happening, creating trauma in the brain. Night terrors are also traumatic for parents and family members who observe them. Often with night terrors, the patient appears to be awake, walking, talking, screaming, and crying, trying to get away from the threat they're dreaming about. Children will often cry out for their parents, begging for help, while simultaneously pushing their parents away, recoiling in fear. While the child most likely will not remember a night terror in the morning, as a parent, if you've been awake with your child through the night terror, you most certainly will remember. The third sleep issue in fear of harm is excessive restlessness during the night and alterations in circadian rhythms. Excessive restlessness is easy to observe both during and after the fact, with frequent middle-of-the-night awakenings, trips to the bathroom, and bed sheets, pillows, and pajamas in wild disarray. The disruption in circadian phases is also easy to spot. Fear of harm patients have a very difficult time winding down in the evening and preparing for bed. When most people are starting to feel tired out from their day, kids with fear of harm are having their energy ramp up and find themselves wide awake and unable to settle down just as sleep should be setting in. This makes bedtime routines incredibly difficult as the child experiences the combination of rising energy levels, anticipatory dread about being unable to fall asleep, and anticipatory fear of the nightmares they know are coming. After excessive difficulty falling asleep, staying asleep, and experiencing nightmares, the child with fear of harm will then have their morning sleep disrupted further by experiencing sleep inertia. Just as they should be waking up and getting ready to start their day, they fall into a deep sleep, so deep that it's very difficult to wake them up and get them out of bed, and these children often have difficulty getting to school and activities on time as a result. Symptoms are not due to a general medical condition. As with all illnesses related to mental or physical health, it's important to make sure that the symptoms are not being caused by some other illness. For example, with fear of harm, it would be important to make sure that the symptom of having warm or hot ears isn't the result of having the flu and having a fever. Or we'd want to make sure that the restless sleep wasn't being caused by sleep apnea. Some of the fear of harm criteria may overlap with symptomology from other DSM classifications, as well as physical illnesses, but by considering, exploring, and ruling out other causes of symptoms, we can gain confidence that we're coming to the right diagnosis. A family history of recurrent mood disorder. This is perhaps the simplest criteria to explain, because we all understand that certain traits and conditions are passed from parent to child through our genes, and that this means that certain illnesses wind up running in families. Everything from green eyes to breast cancer to a predisposition towards depression can be inherited. The same is true in the case of fear of harm. If close family members, like parents, siblings, or grandparents, have a mood disorder, bipolar disorder, or even an addiction like alcoholism, it increases the likelihood that a diagnosis of fear of harm is correct. These symptoms play out similarly in whatever setting the child happens to be in, be it either at home or at school or at another activity. Because transitions are difficult times for children with fear of harm, the school day itself can present many challenges as they're asked to repeatedly transition from one subject to another, from one activity to another, or from classroom to playground, regardless of whether or not they feel ready. Additionally, School anxiety is heightened by having to take tests, work in groups, and manage a socially complex classroom environment. Fear of school can result in evenings and weekends where the child experiences a heightened state of dysregulation as they anticipate the struggles they'll face in school. This causes any other interruptions or unexpected events that occur during the day to be met with increased behavioral symptoms and activities related to preparing for school, such as getting dressed, packing lunch, getting out the door on time, or even getting to bed on time the night before, become fraught with physical and verbal aggression. This difficulty with transitions also affects the flow of the school year itself, with symptoms being more pronounced as the school year begins and ends. And the change of seasons through the fall and then in the spring, with significant temperature fluctuations over both the course of the day and over weeks, also contributes to escalating symptoms and mood instability. Now that we understand the 7 proposed diagnostic criteria for fear of harm, we can circle back to the idea of a biological symptom in our next video in this series and figure out how to know for sure if it's fear of harm or not.